We're going to start. I got nothing to disclose, so please, can you scan the code? The so easy questions, ولكن نحتاج نكون سريعين. Case reports تكون حاطة تقريبا 30 seconds, بس whenever I have good number of answers, then I'm going to just move to the next one. It's not for the seniors and experts. Yes? دحين هبدأ اليوم. Yes, I'm going to open it now. خلاص؟
Try to be quick because we are running short of time, please.
Yeah.
And even for the answers.
We have 10 case scenarios. We need to be quick. Yes. لا لسه لما نبدأ الكيس سيناريوز حتبدأ بس دخلتوا أسماءكم كلكم. Okay. You ready? بسم الله. Can I have the IT, please? So you're going to start meanwhile. Can I have the IT, please? So we have a 10-year-old boy who was admitted to the deformities of the fingers, toes, noted since 5 years by the parents. He noted to have knee, ankle, and wrist swelling, and he never had fever or skin rashes. There's negative family history of any musculoskeletal or autoimmune disease. And his examination was he had normal vitals, no lymphadenopathy, and he only had arthritis in bilateral knee, ankles, and wrists. He had normal labs, including anti-ANA and rheumatoid factor. Abdominal ultrasound showed mild hepatosplenomegaly. Synovial fluid analysis showed a white count of 400 micromole, protein 2.5, and LDH of 432. So these are the clinical pictures and the x-rays. ما تطلع لي هنا. So I'm reading. No, that one. The slides أصلا ما تطلع هنا. أنا شايفتها. Genau. Okay. So, what is the expected cardiac finding on these patients? Myocarditis, pericardial effusion, valvular heart disease, normal echocardiogram. دحين دقيقة. So question one. تحطوا answers. ما في answers طالع؟ دحين لا. يلا بسم الله. خلاص؟ So the accurate answer is pericardial effusion. So what is this? So pericardial effusion is the accurate answer, and this is what was found for this patient. This is the echo. So this is CASP. CASP is a disease which is characterized by the tetrad, camptodactyly, non-inflammatory arthropathy, coxa-vara deformities, and a pericardial effusion. Arthropathy involves the hips, knee, and joint and ankle joint, although TMJ joint involvement was reported along with the PG4 gene mutation. And coxa-vara is noted in 95% of cases, and pericardial effusion has been reported in more than 30% of these cases. And it was reported around 41 as case reports in Saudi Arabia. And therapeutic management is the only symptomatic and require a multidisciplinary approach. Now we'll move to the second question. This is a 3-year-old boy presented to the clinic with 6-month history of pain, swelling of the right knee, and no history of trauma. The patient was treated as GIA with prednisolone and methotrexate for a period of time, and his systemic review was unremarkable. He had no family history of any rheumatological disease. Physical examination showed swelling and limited range of motion of the knee with patella dislocation. His lab tests were all unremarkable, and his knee X-ray showed soft tissue swelling around the knee joint. An MRI was done and showed large synovial mass of signal mass of synovium posterior to the lateral patellar facet, and causes lateral dislocation of the patellum. Now, synovectomy was done, and histopath showed foamy macrophages, spindle cells, multinucleated giant cell, and considerable amount of hemosiderin deposit. The question is, what is the most likely diagnosis? Is this unclassified synovial chondromatosis, tuberculous arthritis, hemophilic arthropathy, or pigmented villonodular synovitis? طلع السؤال صح؟ دحين.
Yeah, it's coming.
We'll give 10 seconds بس السؤال ده. Okay. So everyone has ايوه يا ريت. Okay. So do I go to the PowerPoint in the same way? Okay. So the accurate answer is pigmented villonodular synovitis, which is a rare, a proliferative process that affects the synovial joints, tendon sheath, and basa membrane. And the youngest patient has been reported was 12 months of age. Knee involvement is common in pediatric age group, and most children with polyarticular disease have other congenital problems suggesting a probable basic genetic basis for this syndrome. And it has been reported in Noonan syndrome and fetal Heidenstein syndrome. And joint aspiration is usually sterile, and only 33% of reported cases of pediatric PVNS produce positive finding on initial X-ray. So this is a study of a systematic review for 44 patients, and most of the joints involved were the knee joint, which is 21 patients. And the most effective screening method to diagnose this is MRI, and there's no standard for treatment. And there are some reports of systemic medication targeting the colony-stimulating factor 1 has been reported for patients with diffuse relapse or multifocal BVNS. So we always need to think of or revise our differential diagnosis in cases of patients who are refractory to initial treatment. So case 3, this is a 10-year-old girl who was referred to a tertiary center as a known case of systemic GIA based on her initial presentation of fever and arthritis. She was treated on non-steroidal steroids and methotrexate for a period of time, and attempts to taper steroids leads to recurrence of her arthritis and fever. And 12 months after cessation of her methotrexate, she developed a foggy vision. Ophthalmological examination showed panuveitis. Her ANA were borderline, rheumatoid factors negative, chest X-ray showed no lymphadenopathy, and AAC inhibitor was normal, and genetic test showed mutation in NOT2. Now, the true statement about the disease include all of the following, except granulomatosis, granulomatosis dermatitis, typically the earliest sign. Ocular disease is well controlled with local treatment plus minus anti-TNF. The presence of boggy swelling, camptodactyly, bilateral symmetrical arthritis are the most consistent clinical clue to diagnosis. Renal involvement is a major cause of mortality. واحد اثنين. Okay. So, كمان نعطي 10 seconds بس يلا بسم الله. خلاص 25 answered 26 7. Okay. Whoa. So let's see to the so the accurate answer is ocular disease is well controlled with local treatment. This is the wrong answer or the wrong statement. So we're talking about Blau syndrome. So Blau syndrome is a rare autoinflammatory disease caused by gain of function of a mutation of NOT2 gene. So it's complete triad of arthritis, uveitis, and dermatitis may not be present at the time of presentation, which make diagnosis a bit difficult. Fever is an important manifestation in young children, and the polyarthritis, boggy synovitis, camptodactyly, and deformities of small joints of the hands are the important clues. Uveitis are very difficult to treat in these patients, and usually they require immunosuppressants, and renal involvement, when it occurs, it's usually a cause of mortality. So this is, as you can see, the maculopapular rash, the camptodactyly, and the boggy synovitis, and the uveitis for these patients. So when to think of Blau syndrome in infants with fever and fixed rash, in children with fever, rash, and uveitis, patient with polyarticular arthritis and uveitis. And in a patient with arthritis with a family history, and those are refractory to treatment, and patient with non-cascading granuloma in tissues. So case 4, this is a 10-year-old girl who was admitted through the emergency department with history of headache, speech disturbances, uncontrolled laughter, and urinary incontinence for a month. Neurological exam revealed disturbance of orientation, ataxia, dysarthria, and pseudobulbar signs. Motor and sensory examination were normal. EEG showed bioelectrical slowing, diffuse one, and CSF protein level was 139 with oligluconal bands were negative, and other labs investigation were normal. Vasculitis pernal were normal, and he had by audiometry bilateral sensory neural hearing loss. His brain MRI showed small multifocal hypertense intense region, especially in the corpus callosum. So based on the previous finding, your next step to finalize your diagnosis, CNS, bilateral hearing loss, is genetic testing, spinal MRI, echocardiogram, fundus fluorescent, and geography for this particular case. هذا صعب. genau. خلاص. So genetic testing was the most answered choice, but it was wrong. So we're going to go for fundus fluorescence and geography. So we're talking about Sussex syndrome, which is a rare autoimmune disorder characterized by classical triad of hearing loss, encephalopathy, and branch retinal artery occlusion, which is the brow. The full triad may not present initially as a first presentation, only 13% of cases, which make the diagnosis a bit difficult. And at the onset, CNS symptoms are the most frequent, followed by visual, and lastly, the hearing loss. It could be monocyclic or polycyclic or chronic cutaneous form. So this is the arterial wall hyperfluorescence for the angiography, for the ocular angiography. So recently, some authors have suggested that central callosal lesions on MRI can be considered as independent diagnosis for definite diagnosis of Sussex syndrome. Therefore, in patients lacking the clinical triad, imaging could be helpful. And the treatment all are based on case series. Guidelines are lacking. And most of the medication being used, steroids, IVIG, MMF, and cyclophosphamides, and antiplatelet, anticoagulant as an adjuvant therapy, cochlear implant, and oxygen therapy for retinal occlusion, and cochlear implant, of course, for hearing loss. Okay, so case number 5. This is a 13-year-old girl admitted with gradual exertional dyspnea that improved on leaning forward for 2 months. She had hemoptysis, night fever, decreased appetite, and weight loss. Systemic review were unremarkable. Echo showed massive pericardial effusion. Therapeutic pericardiocentesis revealed exudative fibrinous effusion with marked leukocytosis. So her CBC, LFT, and renal function tests were normal. She had high inflammatory markers. ANA were negative. Complements were normal. Thyroid function were normal. Blood and respiratory cultures and virology, tuberculin tests were all negative. So she was put on empirical antibiotic, improved, and discharged home. Admitted few days later with same manifestation and very more toxic looking, normocytic normochronic anemia, and again pericardial effusion. And due to extensive adhesions, pericardiotomy was recommended and showed high number of IgG4 positive plasma cells. An easy question. Pathology revealed marked storiform fibrosis with excessive lymphoblastic infiltrate. Now, ايش المفروض اعمل؟ Okay. Yeah, so IgG was 2,600, serum IgG4 was 168, and serum, the ratio IgG4 to IgG was 25% only. So based on the 2020, this is just to bring up the 2020 criteria, 2020 revised comprehensive clinical diagnostic criteria of IgG4-related disease. Would this patient have a definite, possible, or probable diagnosis of IgG4? حقيقي؟ طيب مشكلة. أيه خلاص انتوا حطوه كلكم لأنه هو قاعد يقلب الباوربوينت ما أعرف ليه. So this is the definite diagnosis, بس عشان no. So we know that IgG4-related disease is a rare disease, and it's a progressive and sometimes fatal disease. And it has been reported in pediatric in 59 patients. And it affects mainly the orbits, lacrimal and salivary gland, pancreas, kidney, and peritoneum. And out of the fifth, no? هو ماشي حالي كده كويس خلاص.
لا هو مش ماشي.
ماشي الحال.
لا ماشي.
ها؟ والله طيب. Out of the 59 patients, there's a case series in from one center, 8 patients, and most of them had ophthalmological involvement. So based on we have the 2011 and 2020 criteria. The only difference is that there's a pathological finding or criteria that includes A, B, and C instead of only the ratio and the number. You have also the tissue fibrosis, predominantly styrofoam fibrosis. So if you're going to apply the previous scenario on 2011 criteria, she would have a probable diagnosis, while applying in 2020 criteria, she will have a definite diagnosis. Here. So case 6, this is a 12-year-old girl presented to the clinic with history of left knee joint swelling since 7 days with no fever, no skin rash, and systemic review, all unremarkable. Examination showed only left knee swelling. Upon investigation, she was found to have positive ANA and persistent glucosuria, for which she was investigated. Hemoglobin A1C was normal. The glucose tolerance test was normal. So other investigations showed anti-SSP positive. The other antibodies were negative. And ultrasound neck showed enlarged bilateral lymph nodes and parotid gland. And Schirmer test was positive. Now, because of the persistent glucosuria, she went into renal biopsy. The true statement about the renal involvement in the former case: the long-term outcome of renal damage in pediatrics is usually poor. Tubulointerstitial nephritis is the main renal involvement. Glomerular damage usually occurs in more than 50%, and renal involvement occurs in more common than in adults. So which one is true? اوكي ما شاء الله. طيب خلينا اصلا الحين كمان شفتوا الجواب ده؟
كانت في إجابتين هدية من الدكتورة. كان في إجابتين هدية كانت من الدكتورة عموماً.
Are we good in time? الوقت كويس؟ طيب. لا. 6 minutes? okay. So لازم أفتح هذه صح؟ Okay. So tubulointerstitial disease is the main renal involvement in primary Sjogren's syndrome. So renal manifestation account only up to 11% of pediatric cases, and the main renal damage is tubulointerstitial disease. Other forms could be RTA, mesenteric porphyritic nephritis, and hypokalemia. And the glomerular damage is usually rare, and long-term outcome of renal damage in pediatric Sjogren's is usually favorable. So case 7, this is a 6-year-old boy presented soon after birth with erythematous eruption, hemorrhagic blisters, initially on the palms and the entire body, accompanied with solitary subcutaneous nodules and violaceous periorbital swelling. His rash was worsened during the fever episodes, and his biopsy showed inflammation with the presence of lymphocyte, neutrophils, and macrophages and mastocytes. At the age of 2, he presented with fever, an extensive rash, purple periorbital swelling, hypertrichosis, lipodystrophy, Ullmann face, tachydyspnea, hepatomegaly, and failing to thrive. He had anemia, neutrophilia, and high inflammatory markers, was treated with methotrexate, hydroxychloroquine, and and methyl prednisolone, and his genetic test showed compound heterozygous mutation in proteasome gene. So the most likely diagnosis, Sweet syndrome, NOMID, MVK, or Candle syndrome. So yeah, the accurate answer is Candle syndrome, which is the chronic atypical neutrophilic dermatosis, lipodystrophy, and elevated temperature. Usually starts in the first month of life, and the skin lesions are the first clinical signs to appear. And lipodystrophy usually starts in early childhood and is usually well established before puberty. Patients have a variable outcome of Candle syndrome, and some patients have had a lethal course due to acute attack of inflammation. One of the newest treatment has been used in 8 patients with favorable outcome is baricitinib, but still waiting for other studies to confirm the efficacy. Next case is, this is a 14-year-old boy diagnosed with CRMO 4 years back and started to have skin rash over the limbs, chest and back, joint swelling of both knees and ankles. His examination showed synovitis in both knees, wrist, elbows, and sternoclavicular joints with multiple anisoform pastoral lesions over the chest, back, face, and upper and lower limbs. He had mild leukocytosis, high inflammatory markers, ANA and HLA-B27 were negative, and skin biopsy showed giant cells in the epidermis and lymphoblastic infiltrate. This is the X-ray and the skin lesions. So the false statement about the case diagnosis, it is considered one of the polygenic autoinflammatory disease. Uveitis is a rare manifestation. It has a positive response to anti-IL-1. Diagnosis is based on clinical radiological finding with no genetic association. خليها 10 seconds بس هذه. So the false
We have only
statement.
2 minutes, Doctora.
Okay. Big 2 case scenarios. So the لازم نحسب التكنيكال issue كمان between. So it has a positive response is the accurate answer or the wrong answer. So the treatment usually is adalimumab, showed excellent cutaneous response along with osteoarticular involvement, and tofacitinib is another promising therapy, although data are still limited to case reports. So this is a 10-year-old girl presented to the emergency department with history of loss of consciousness and abnormal movement. She had only history of head trauma at the age of 3 years, and on examination she had 2 atrophic lesions in the face, alopecia in the right parietal zone, and abnormal positioning of the teeth. So all are true regarding to this condition, except it is associated with more than 50% neurological manifestation. MTX is a treatment of choice to stop the active phase of the disease. Interbranchial branchial brain calcification, the same side of the facial abnormality, are the most significant CT finding, and it is not associated with organ involvement. One more, yeah. One more case scenario بس فيها سريعة 3 أسئلة. خلاص؟ So yes, the answer of it is not associated with other organ involvement is the wrong answer or the accurate answer here. So we're talking about Perry-Romberg disease. Just to mention that the other organ involvement is cardiac, endocrine, autoimmune disorder, and congenital disease such as Poland syndrome, microcephaly, and kidney malformation. And the treatment is to give methotrexate to stop the progression of the disease, and then the mild moderate cases will go into silicone filler with collagen, and severe cases with grafting of cartilage, bone, fat, and skin. Last case, this is a 5-year-old, previously healthy girl presented with near-onset persistent red burning hives covering the large segment of her body. Associated symptoms include angioedema, shortness of breath, and diarrhea. The lesions resolved after 24 hours, leaving behind areas of bruising. Physical exam showed the patient appeared well with the scattered variable size paraperic patchy and articarial plaque on the torso and extremities. The labs revealed leukocytosis, elevated ESR, normal C1q level, and degrees C4 level. And 2 weeks after initial presentation, she developed the same paraperic eruption accompanied by acute hypoxic respiratory failure. Now we have like 3 questions, quick questions. What is the most likely diagnosis? Urticarial vasculitis, IgA-mediated vasculitis, unclassified vasculitis, or urticaria multiforme? So yes, IgA urticarial vasculitis. And which of the following is not common systemic manifestation of hypocomplementaric urticarial vasculitis syndrome? Chronic obstructive pulmonary disease, glomerulonephritis, encephalopathy, uveitis, arthritis.
So last question, Dr.
أيوه. خلاص. ما بيطلع. Oh, okay. 9 answered right. So, encephalopathy is not included. And the last, what is the preferred first-line treatment for normocomplementaric urticarial vasculitis? Preferred first-line treatment. Steroids and antihistamine. So we have 3 distinct types of urticarial vasculitis: the normal complementaric urticarial, the hypocomplementaric, and the hypocomplementaric vasculitis syndrome. And the prognosis depends on the severity of systemic involvement. Pulmonary disease is the major cause of death, and acute laryngeal edema can be life-threatening. Now we can look at the...
Okay, you need to conclude.
دكتور عسيري.
مبروك مبروك دكتور عسيري.
عسيري.
عسيري